afternoon, everybody. It is Dr. K here, and we're just doing a case that I recently did, and I'm just gonna kind of narrate this on the fly. Um, so I haven't watched this video in a little bit of time, but we've got good exposure. We've got some viscoat on the cornea. That's why there's those bubbles that you see. They're not actually inside the eye. They're on the surface in the viscoelastic. Make a side port incision, and I make it parallel to the iris. If you angle down, then it tends to leak more. So make your side port parallel to the iris, use a diamond blade, and then some viscoelastic. Try and get an expanding kind of bolus there, and if you wiggle the cannula on the way out, it does tend to get rid of the bubbles. I learned that from Dick McCool. You mark the cornea, that's about a 5.5 millimeter marker, and then I use a fixation ring, and I just do a single plane incision, 2.4 millimeter blade. I do take my time entering the eye because I like to have a nice entry wound. I don't like that chevron triangle shape. I like to keep it as a straight an entry as possible. And then I use a 0.12 forceps and a cystotome to begin the Capsulorhexis. I'm sorry, a 0.12 forceps and Utrata. I used to use a cystotome. I don't use that anymore. I just go straight in with the Utrata and grab. I try and make the Capsulorhexis as round as possible. I don't necessarily follow the outline that I made. I oftentimes will follow the iris and keep equidistant from the iris, about 360 degrees. But I take my time with the Capsulorhexis. I like it to be nice and round because I really appreciate the appearance of a well-centered, round Capsulorhexis at the end of the case. And so if at any time I feel like the way I'm pulling is not getting a circular shape, I will then adjust. So some days I might regrasp 3 or 4 times. Other cases I might regrasp 7 or 8 times. And so I just try and get a nice round Capsulorhexis. I remove the anterior capsule and I hydrodissect with a 27 gauge cannula. I've tried different types of cannulas, chain cannulas, etc., but I usually just go back to the 27 gauge because it's always available. Like if I operate at a satellite clinic, I don't have to get a different instrument, and it seems to work. I get a good hydrodissection, I rotate the lens, and then I will virtually always do hydrodelineation unless it's an extremely dense lens and there's not much epinucleus to hydrodelineate. After that, I reinflate with viscoelastic. I like to protect the cornea. Then I enter with the phaco. Try and irrigate prior to entering to make sure that the irrigation is the way I want it. I want to make sure that you have good irrigation. Then I go into quadrant mode and I clear the tip and I clear the anterior portion of the lens. And then I immediately start making a central groove. I tend to do a stop and chop fashion. I groove until I am comfortable, until I feel like I can see adequately enough, or until I feel like there is a clear portion to the posterior lens such that I'm at the maybe posterior epinuclear shell. Then I crack and rotate. I don't need to get a full thickness crack as long as I feel like I can free up the first quadrant, which is what we're doing here. Occasionally that first quadrant doesn't clear up, and either I'll continue to go after it or I'll move to the next quadrant. And then rotate and continue, propagate that crack, remove the next quadrant. And again, these are kind of more central nuclear pieces. I leave the epinucleus and crack again and take whichever piece comes out more easily. I try and keep the phaco tip centered. I don't usually like a terribly aggressive tip. In the past, I might have used a more aggressive tip, but these days I try and just keep the tip smaller. I keep the phaco tip central. It's not a terribly dense cataract, this particular one, but keep the phaco tip central and remove the central lens material. Then I go back for the epinucleus. And I take whatever comes. And if something doesn't come from an epinuclear standpoint, I rotate to the next point. But in this case, we seem to get most of the epinucleus out pretty easily, pretty quickly. And there's your epinucleus. Now we are going to switch to irrigation aspiration. And as I do INA, again, I usually take whatever will come first, whether it's, usually I'll tend to start more kind of inferiorly there and rotate around, at least in this left eye, it's inferior, or start to the left side, rotate around, and I pull, usually not more tangentially rather than centrally, but it depends on the piece that's coming out. So there we're kind of pulling more centrally, and then to get the inferior cortex, I will often just pull centrally. Occasionally I'll use the second instrument to hold back the capsule while I go for some subincisional cortex. Then I always will kind of power wash the capsule with some BSS. I found this a pretty effective technique. It will get the remaining cortical material off the posterior capsule. Sometimes you also find some residual cortical material in the fornix of the capsular bag. In any event, once I do that, I reinflate the capsule with Provisc, and then I do anterior capsular polishing. And I like the anterior capsular polishing. It's just cleaner. You can see the anterior lens cells get liberated, and then even throughout the post-op course, if you're following these patients, you will find that, particularly with these Alcon lenses, which is what we use, there's this capsular fibrosis that does not occur as aggressively if you polish the anterior capsule. So we do some limited polishing of the anterior capsule. Sometimes I'm more aggressive, sometimes I'm less aggressive. And then in this case, I think we are using an auto preloaded lens. I hold the incision with the second instrument, and then I use that same second instrument to provide some counter traction as I inject the lens. And then once the lens is injected, I almost always will use a Sinskey to position the lens. And this was in October. Maybe this isn't it's opening pretty quickly. This might be one of the new Clarion lenses. It opened pretty quickly. And so this, my guess is this is a Clarion lens that we injected. And I've had good use with the injector and the Clarion lenses. You do sometimes have to rotate the injector to get the lens in the proper orientation. So that's one caveat. Maybe I should do a separate video on that since those are kind of new lenses. I go behind the lens always initially, and I use usually the cortex removal behind the lens, and then I come interior and I switch to viscoelastic removal. I sweep the angle thoroughly, and then I move more centrally and get whatever viscoelastic might be on the central cornea. As you can see, that is a nice, well-centered Capsulorhexis, very round. I don't leave a lot of overlap, but I try and always leave some overlap. Then I hydrate the wound with some BSS. Don't forget to hydrate the roof of the incision. If you hydrate the roof of the incision, you tend to not need as much BSS laterally, and so then you don't get as much corneal edema. I just went behind the lens to kind of liberate some cortical material that I was able to see there. So we will get that out, and then again hydrate the roof. I will always use some moxifloxacin at the end of the case to try and minimize the risk of endophthalmitis. Nobody wants endophthalmitis, so there's the moxie. And then once I put that in, I will rehydrate the incisions and check them with a Wexel. There's a little piece of material there. We'll get that out and finish hydrating the incisions. I never worry about washing out any of the moxifloxacin. Once it's in there, I think it's in there in an adequate concentration. And I am pretty meticulous about making sure my incisions are sealed. And that's the case. Thanks, everybody.